Hello and welcome. I welcome you all to OrthoTV classroom. I am Dr. Anagha Kadam, Assistant Professor, Department of Musculoskeletal Physiotherapy at Sanchiti Institute for Orthopaedics and Rehabilitation, College of Physiotherapy. Today, in this session, we are going to talk about rehabilitation for Tendoachilles rupture. I'll quickly share my PPT. Yes. So, rehabilitation of Tendoachilles repair. So the agenda for today's session is we'll start with brief introduction. What are the operative overview, or you can say what are the indications to get operated for the same, and what are the best participants that should get operated for tendo-Achilles rupture, and what are the post-operative management for the same. Introduction. So, Tendoachilles rupture is one of the most common injuries, soft tissue injuries, I'll say, that occur. It is more frequent in middle-aged population with men more prone than female. And you can say the people who are more athletic or do exercises are more prone to such kind of injuries. So, how does it occur? Or you can say, what is the mechanism of injury for these kind of ruptures? It is caused by sudden or forceful concentric or eccentric contraction of gastrosoleus muscle. You can also say that acute ruptures commonly occur when pushing off from the weight bearing foot while extended in the knee, but they can also be caused by sudden or violent dorsiflexion of a plantar flexed foot. Means if it is and the foot is in plantar flexion and it suddenly goes in dorsiflexion, at that time the chances of rupture are more. Okay. So what is a common site that the tendon is usually ruptured at? It is often ruptured at the proximal to distal insertion on the calcaneus. It is also called as watershed region due to reduced vascularity. Okay. And at the time of injury, if it is a complete rupture, it leads to pain, swelling, significant weakness in plantar flexion. There is there is sharp pain and pop heard at the time of complete rupture. And how do you diagnose this? It is usually said the Thompson test is positive while complete Achilles tendon rupture, but sometimes there are chances that the Thompson test is negative or is falsely positive, you can say. So at that time, MRI plays an important role in diagnosing these conditions. Okay. So operative overview. Usually these rupture cases, if there is any acute involvement, if there is acute involvement of the tendo-Achilles, it is usually managed non-operatively. But if the patient is an athletic person or has a chronic history of Achilles tendon rupture, or there is a complete rupture of the Achilles tendon, at that time the surgery is indicated. There are two options for surgery, that is primary repair and delayed repair reconstruction. I won't be explaining much about it. In fact, I won't be explaining about it because we are dealing specifically for rehabilitation of tendo-Achilles. So I'll stick to the topic and move forward. So post-operative management. There are two main strategies or rehabilitation framework that we deal with or we work with when we have a patient of tendo-Achilles repair. The first one is the conventional management strategy, which consists of a late weight bearing, obviously, and there is accelerated functional rehabilitation, in which we start with the rehabilitation protocol in an accelerated phase. So we'll start with the conventional management. So in the conventional management, we'll be going week wise. So in the first 4 weeks of the surgery, a dressing and posterior splint set is in equinus removed, which is removed after few days to a week post-operatively. and the compressive dressing is replaced by below knee cast or fixed hinge boot placed with the foot placed in 15 to 30 degrees of plantar flexion, and at 2 to 3 weeks new cast is applied or boot is adjusted in less plantar flexion, means the plantar flexion is reduced. So the weight bearing in these conventional management is non-weight bearing with crutches, obviously. So this is the boot which we fixed hinge boot, right? Which we saw. So if you can see over here, so there are these hinges which helps you in adjusting the plantar flexion which is needed. As I said previously, the plantar flexion was kept in 15 to 30 degrees, and then we started reducing it slowly, right? So this can be done through that. So at 4 weeks, CAM based control ankle motion brace is used, which may or may not allow active plantar flexion but limits the dorsiflexion to 0 degrees. All right. So it won't help you. It will prevent excessive dorsiflexion, but it will help in maintaining it at 0 degree. Okay. So continuous immobilization in cast or very limited motion in brace for additional 2 to 4 weeks. And weight bearing status, non-weight bearing is continued or toe touch weight bearing is started while wearing an immobilizer, which we are giving, and weight bearing is progressed as tolerated. So it is started, but toe touch weight bearing as tolerated by the patient. Then at 6 to 8 weeks, cam brace allowing dorsiflexion beyond neutral. So we started with keeping it in plantar flexion and reducing it, and then keeping it at 0 degree neutral, and then allowing a bit of dorsiflexion beyond the neutral line. And then active range of motion exercises are initiated with brace, full weight bearing, wearing functional brace. Shoe lift is recommended with 1 to 1.5 heel off for additional 2 to 4 weeks. And beyond 12 weeks, functional brace. Functional brace gradually, uh, beyond 12 weeks, functional brace is gradually discontinued by 12th week. So brace use or taping of ankle may be necessary for return to high demand sports. As I have already as I have already said that these surgeries are usually recommended in orthopedic population. So if the patient is into sports, so bracing or taping of ankle is necessary for them to return to sports, and full weight bearing with regular shoes without lift if ankle is pain free, and 10 degree dorsiflexion beyond neutral is attained for weight bearing. And if there is a reconstruction with tendon graft at time periods, um, and you need to remember that if this is reconstruction with tendon graft is done, then all time periods means we will be delaying the treatment right from the week 0 week to the 12th week to 2 weeks longer. So I'm not going to dwell in the reconstruction part again in conservative management because it is same, just we are going to delay the rehabilitation much more longer. All right. So this was the conventional management protocol. Now we'll be saying accelerated functional rehabilitation protocol. So for this, we'll be accelerating rehabilitation a bit, and we'll be dividing it in three major phases. That is maximum protection phase, moderate protection phase, and minimum protection phase. Maximum protection phase will last from 0 to 4 weeks, and moderate protection phase from 4 to 12 weeks, and minimum protection phase, or you can say return to function phase, after 12 weeks. Maximum protection phase, obviously you'll give patient education, you'll explain the patient about the wound care, then how to control the edema by elevating the foot. ROM exercises of non-involved joints are usually started. Initiate ankle active range of motion within 1 to 2 weeks wearing a functional brace or splint to prevent dorsiflexion beyond 10 to 20 degrees of guinus, or to no more than neutral position. If you remember, we started over there from plantar flexion at 15 to 30 degree, then we made sure the ankle is staying in neutral, and then in dorsiflexion. But if you see over here in the minimum protection phase, only we are maximum protection phase, only we are starting with dorsiflexion at neutral or beyond that. All right. Ankle isometrics with the immobilization with immobilizer with first few days after surgery for dorsiflexor inverters, everters, and plantar flexors, and progress to three sets of dorsi inverters, everters after 2 weeks, isometrics for plantar flexion. So first we'll start with all these and then start with isometrics for plantar flexions, plantar flexors. Start with weight bearing of, if you remember, there was no weight bearing for 0 to 4 weeks in the conventional protocol. But over here, usually I, weight bearing as tolerated by the patient is allowed after 1 to 2 weeks by wearing a beyond knee orthosis or ankle immobilized, mostly in plantar flexion or neutral. Progress to full weight bearing after 3 to 6 weeks. We'll start with weight shifting activities in bilateral stance while wearing the orthosis. Parallel bar could be used or stable surface to support the upper extremity. And we'll start with the weight bearing, weight shifting activities with it. Moderate protection phase. So it starts from 4 to 6 weeks and it ends at 12 weeks. So we'll start with grade 3 joint mobilization of ankle and foot joints if they are restricted. There is a non-weight bearing stretches, gentle towel stretch while sitting to increase dorsiflexion. Limit dorsiflexion. We should limit the dorsiflexion to not go beyond neutral. Then initiate weight bearing stretches in sitting with feet on the floor or a rocker board so that your foot stays in neutral position. ठीक है? And standing stretches in bilateral stance, such as standing on a wedge. If it is pain free, if there is pain, so we'll stop it. We won't do it. Then we have to postpone unilateral standing stretches or bilateral standing stretches with heels over the edge of the step until advanced activities are permitted. So you can see over here self stretching of gastro muscle is done to increase ankle dorsiflexion. Your self stretching of ankle and foot into inversion is done by pulling the towel medially. We can even do this for dorsiflexion. All right, and here you can use a rocker board. Maximum protection phase. To improve the strength, OKC exercises for hip, knee, again with elastic resistance, the TheraBand can be started. Begin strengthening exercise for ankle and foot muscle in non-weight bearing position with low resistance TheraBand, with a yellow one. Heel raising, lowering while seating on the floor, rocker board for more resistance, cross thigh over the other leg, standing heel raising, lowering bilateral heels over the edge of the step. Then we'll progress to weight cuff, progress with weight cuff, TheraBand during standing. Unilateral heel raises will be postponed till 12 weeks. Then partial lunges with involved leg in the front. Then bilateral mini squats, toe raises will be done to improve the strength. Over here, you can see we have applied user TheraBand. So for strengthening of ankle everters muscles, and your resistance band is given for dorsiflexor muscle strengthening, and eccentric loading of gastrocnemius muscle is done over here by while keeping the limb unaffected limb here. Okay, then minimum protection phase. After 12 weeks, it starts. Then whatever exercise we did in the moderate protection phase will be progressed to unilateral stance with resistance. We'll start to, will ask the patient, we'll train the patient to descend stairs. Plyometric training can be started over here. Then we can start exercise in a pool over here. Then 16-week onwards, land-based plyometric training can be started. So first, for starting plyometric training, we should always think of starting it in a pool or water body and then bringing it to the land base. Wear functional AFO or tape during high impact or high velocity activities. So this was it for minimum protection phase. As you can see, there was too much stark difference in the conventional management and the accelerated program. So this protocol is usually suited for people who are more into sports. There are some recent advances which I want to tell you. So this is a functional rehabilitation and strength training focused interventions for Achilles tendon rupture and repair, a case report. So this was published in UND Scholar Commons. Over here, you can see that there are the over here you can in this article you can see that they have given IFT stimulation with an 80 to 100 hertz frequency uh, on sweep for 20 minutes. The BAPS board on level 2 in flexion forward, backward, lateral rotation, lateral to increase multi-directional range of motion and left ankle proprioception was given. And ASTYM to the left ankle in order to break down adhered and tight tissues to increase the range of motion was given, and they had really great result with it. So this is one of the case report that you should refer. Secondly, a BFRT training protocol. So in this article, as we know, BFRT has proven to be a big as you know, BFRT has shown tremendous good results in the rehabilitation. So, for in this article, you can see BFRT training was used for Achilles tendon rupture patient. 6 week of BFRT training was given, and a partial restricting cuff was placed at the proximal thigh, and leg press and calf presses were done by the patients at 90 degree of flexion for uh, 4 sets, and they had great results for it. So these are the references for today's presentation. I hope you would have understood the session. Feel free to connect to me if there are any doubts. And that's it from my side. Thank you so much. Yes. And I would also like to thank our technical team of Physio TV, our principal, Dr. Apurva Shimpi, Manisha ma'am, for their support and providing us with this platform. And yeah, stay tuned for more updates.